An 87-year-old female presented with a headache. Magnetic resonance imaging revealed a 4.4 centimeter hemorrhagic mass in the right frontal lobe. A hemorrhagic metastasis was favored. Before we look at the histology, consider this question. What primary tumors tend to present with hemorrhagic metastases to the brain? Textbooks tend to list the most common as melanoma, renal cell carcinoma, and choriocarcinoma. In my experience, melanoma leads this list by far. Renal cell carcinoma is more likely to spread to the skull rather than produce brain metastases. A metastasis from a choriocarcinoma is rare. Now let's turn our attention to the histology. The tumor is hypercellular and composed of a pleomorphic population of cells with elongated and irregular nuclei. The tumor cells blend in with the brain tissue with no evidence of a circumscribed border. These are features of an infiltrating glioma. Metastatic tumors characteristically have a sharp border that separates the malignant cells from the surrounding gliotic brain tissue. The nuclear features shown here are characteristic of astrocytic differentiation. One way to think about glial nuclear features is to use a food analogy. Oligodendroglial cells have nuclear features similar to an orange, referring to the ovoid shape of the nuclei. In contrast, astrocytic cells have nuclear features more in keeping with an Idaho potato. The tumor cells show a tendency to collect around blood vessels. This is accompanied by vascular alterations, including thrombosed blood vessels. This image shows the characteristic vascular endothelial proliferation. Even if necrosis is absent, this finding is sufficient for a diagnosis of glioblastoma. Note the characteristic features, including tufting and multi-layering of the endothelial cells. The only immunohistochemical stain that I use routinely for these cases is mutant IDH1. This is the antibody to the most common mutant protein, which is the result of the R132H mutation. In this case, IDH1 was negative. The diagnosis is glioblastoma. Of course, I send the case out for PCR studies to look for less common mutations in IDH. These very rarely come back positive. In the rare event that an IDH mutation is found, I will issue an addendum with an integrated final diagnosis. The World Health Organization suggests the terminology astrocytoma IDH mutant, grade 4. Of course, in my opinion, this is simply a glioblastoma with an IDH mutation. We have known for years that most glioblastomas are IDH wild type. Now, with the 2021 edition of the World Health Organization classification system, the IDH wild type status is now considered to be a required feature. In my opinion, glioblastoma is a morphologic diagnosis. If an IDH mutation is present, the tumor is still a glioblastoma. It just happens to have a mutation in IDH. This may change the prognosis, but it does not change the tumor morphology. Now let's discuss the topic of glioblastoma. Glioblastoma is an infiltrating glioma with dense cellularity, cytologic pleomorphism, astrocytic nuclear features, mitotic activity, vascular endothelial proliferation, and necrosis. Most cases will have both vascular endothelial proliferation and necrosis. Both are not necessary for the diagnosis. Vascular endothelial proliferation without necrosis is sufficient for a diagnosis of glioblastoma and vice versa. Glioblastoma is the most common primary brain tumor, occurring principally in adults, with a mean age of around 65 years. Almost all are sporadic, with no known environmental risk factors. A very small percentage of cases arise in patients with inherited tumor syndromes. These syndromes include neurofibromatosis type 1, Li-Fraumeni syndrome, Turcot syndrome, and Lynch syndrome. Tumors arise in the cerebral hemispheres. In around 10 to 20% of cases, the tumor extends into the corpus callosum, which is a feature that is quite specific for high-grade gliomas. Glioblastoma only rarely involves the cerebellum, brainstem, and spinal cord. The most common presentation is a rapidly worsening headache, often accompanied by nausea and vomiting. Seizures are also common. The characteristic imaging finding by MRI is that of a ring-enhancing lesion. Most tumors are solitary, but they can be multifocal. Patients are treated with surgical resection, followed by radiation and chemotherapy. The most commonly used chemotherapy agent is temozolomide, which is an alkylating agent. This agent works by converting to a highly reactive compound, which results in the transfer of methyl groups to the O6 position of guanine. This leads to mismatched base pairing with thymine during DNA replication, causing programmed cell death. Unfortunately, most tumors express a protein that removes the methyl groups from the DNA, which allows for the tumor cells to survive. This protein is O6-methylguanine methyltransferase, also known as MGMT. Expression of the MGMT protein is under the control of a promoter. Methylation of the MGMT promoter shuts down expression, which leads to increased susceptibility of the tumor to the chemotherapy. Unfortunately, most glioblastomas are non-methylated, which means that MGMT is expressed, allowing for the tumor to fight the effects of the chemotherapy. We have known for many years that glioblastoma cases very commonly have copy number alterations of chromosomes, particularly polysomy of chromosome 7 and monosomy of chromosome 10. A subset of cases, around 40%, have amplification of the epidermal growth factor receptor gene on chromosome 7. A majority of cases, around 70 to 80%, have promoter mutations in the telomerase reverse transcriptase gene on chromosome 5. Of course, the World Health Organization has now further complicated the job of the morphologist. They have now introduced the concept of the so-called molecular glioblastoma. For example, say you make a diagnosis of a low-grade diffuse astrocytoma, grade 2, based on low cellularity, absence of mitotic activity, a low Ki67 labeling index, say 1%, and absence of vascular endothelial proliferation or necrosis. Then you find out a month later that molecular testing revealed a TERT promoter mutation. Does that make the tumor a glioblastoma? In my opinion, the answer is no. Grading is based on morphology, which tells us where the tumor is in its evolution. The molecular findings give us a clue as to the future of the tumor. The tumor is presently low-grade by morphology. I believe that morphology and molecular findings should be separated. Nothing has really changed. 20 years ago, we knew that a subset of low-grade gliomas had monosomy of chromosome 10, and that this was predictive of tumor recurrence and progression. This information was added to the pathology report in the form of an addendum. However, the morphologic diagnosis remained unchanged. Now we are expected to change the diagnosis to a glioblastoma, despite the low-grade histology. Perhaps the system is progressing and evolving. Nevertheless, this complicates the day-to-day practice of pathology. Now for a few questions. What chromosome typically has an excess copy number in glioblastoma? Also, what chromosome tends to have a reduced copy number? Glioblastoma tends to have an excess copy number for chromosome 7 and a reduced copy number for chromosome 10. This is generally referred to as polysomy of chromosome 7 and monosomy of chromosome 10. What gene on chromosome 10 is often implicated in the development of glioblastoma? The answer is the P10 gene, which is known as the phosphatase and tensin homolog gene. This is a tumor suppressor gene that is frequently deleted or mutated in glioblastoma. What gene is most commonly amplified in glioblastoma? The answer is the epidermal growth factor receptor gene, which is located on chromosome 7. This concludes our discussion of this case of glioblastoma.